Well, hello, and welcome to my case study video on pediatric pharmacology and pain. So this case study is about a child who's 10 years old, and this child was what we call an ex-preemie, or born premature, at 28 weeks gestation. Currently, this child has cerebral palsy, which you will be learning about in future modules, intellectual disability as chronic illnesses, and then also acute illnesses of recurrent pharyngitis. So this child has had repeated sore throats and otitis media. So this child is being admitted to the hospital for a tonsillectomy and ear tubes. We call PE tubes, or pressure equalizing tubes. So don't worry about the acute illnesses and understanding those, but just focus on this child is developmentally delayed, has intellectual disability, and we are going to need to prepare this child for this procedure that is upcoming, and we'll follow this child through her course of hospitalization and how we will manage her pain, and also pay attention to the family-centered care techniques that we will use throughout the case study. So preparing the child and the family for the procedure. So we do want to emphasize atraumatic care when the child is undergoing hospitalization, painful procedures. So this starts before the child is hospitalized. It starts with the family as well. So usually we'll have the child come to the unit where they will be staying so they can get familiar with the smells, the sights, the sounds, the equipment that's being used. And pens up, we will always try and have the child play, because remember, children learn best through play. We will also be orienting the family to the unit, meeting some of the staff, reviewing some of the family-centered care techniques that we will be using, which means incorporating the parents into the care plan of the child. So when this child is admitted, the nursing process, of course, starts with assessment. So what kind of assessment do you think you will need before this child is cared for? Well, first we need to understand the child's developmental level. We already know that the child has intellectual disability. This used to be called mental retardation. How delayed is this child? Cerebral palsy occurs after a child has had some sort of brain injury. And again, you will learn more about that in future chapters. But also the child has not just physical disabilities, but intellectual disabilities as well, and is developmentally delayed. So we need to understand, what level is this child at? We care for the child according to their developmental level. We need to ask, has this child been in pain before? And ask the parents, did this child respond in a certain way? How do you know that the child is in pain? If the child is fairly nonverbal, we need to look at the cues and clues from the child regarding their pain response, and also, depending on the parents, to let us know if this is how the child acted the last time they were in pain, because different pain experiences will affect all children. We need to understand what the child's functional ability is. Is the child able to feed themselves? Are they able to dress themselves? Because this is a pens up. We don't want to do more for any patient than they're able to do for themselves. A lot of nursing students will get this question wrong on NCLEX, and I think it's because nurses are compassionate and we want to do as much as we can for patients. but we need patients to reach the level of ability that they are able to. So if we do everything for them, then that's not good. They won't be able to um, take care of themselves. So we need to encourage them. So it's not being unkind, but it is getting them back up to their functional ability. We want all children to function at the highest ability possible for them. We want to understand if the parents or caregivers, because remember, not all of the family caregivers are parents. They may be guardians, they may be foster parents. So we need to understand who is going to be with this child and when will they be there. We welcome parents and caregivers to stay 24/7 if they're able. But a lot of parents have other children they need to take care of. They have work responsibilities. They may not be able to stay. We want to know that ahead of time so we can prepare because this is another pens up. We don't expect parents or any family members to provide nursing care to any patients. If they want to and they are able to, then we welcome that. But we don't staff our nursing units expecting parents to provide nursing care to patients. We also want to find out what are the activities that the child likes to do. And then lastly, we're going to be providing a focused assessment for the child. Of course, we will do a complete head to toe assessment. But when that child is post-op, what are the things that we're going to be focusing on? We know that we want to focus on the airway, always airway, breathing, circulation, but definitely after a head, eyes, ears, nose, and throat surgery, we want to focus on the airway. We're going to be looking at their vital signs, of course. We're going to be assessing pain because the child has had surgery, so we expect there may be some pain. We're going to assess for bleeding. This child has had surgery, so we need to watch out for the potential complications of that. The child is having surgery on their ears and in their throat. That's where we're going to be looking for bleeding. And circulation, of course, checking pulses, capillary refill, listening to the heart, and so forth. So our assessment. So what did we find with this child? Well, through our assessment of reading the notes and also through talking to the parents, we know that this child's developmental level is severely delayed at approximately a 1 to 2-year-old intellectual ability. The child has had surgery before, and the parents know that when the child is in pain, they moan or make a facial grimace. The child's functional ability is mainly non-ambulatory, so the child does need help with eating, with dressing. The parents luckily will be able to stay, at least one parent will be able to stay with the child 100% of the time. So that's wonderful. So we will discuss family-centered care with the parents. The child likes to listen to music and also works with an iPad pointing at pictures and communicates in that manner. Airway. We know that the child will potentially need occasional oral suctioning due to excessive secretions. So what did we find? The child had a successful surgery. So post-operatively, the child's heart rate is 150, blood pressure is 120 over 85, temperature is 98.4, respiratory rate is 22, the lungs are clear to auscultation bilaterally, the heart has a regular rate and rhythm with no murmurs. There's no bleeding from the ears or the mouth. Capillary refill is less than 3 seconds. Radial pedal pulses are strong bilaterally. How are we going to assess this child's pain? Are we just going to wait till they moan? No, we are going to use the FLAC scale, which stands for face, legs, activity, cry, and consolability. So when we are assessing this child, we're looking at their face, and the child is frequently having a clenched jaw. So we rate this as a 2. The child's legs are drawn up and they have a rigid posture. That gets a 2. The activity is rigid. Sorry, the legs were drawn up, so that was a 2. Activity was a 1. The child was constantly shifting, seemed like they were uncomfortable, trying to get a comfortable position. The child is moaning, so that deserves a 1. And consolability, when the parent is by the child's bedside, massaging their back, talking to the child is consolable, so it's a 1. So we rate this child's pain a 7 out of 10. So how are we going to manage this child's pain? First, we are going to involve family in this family-centered care environment. The parent is at the bedside and consoling the child. We're going to ask the parent, how do you think the child would respond if we put some music on? Do you think that would help the child? Yes, I do. So we put music on. We invite the parents into the rounds with the child. So when the physicians and nurses do rounds on their child, we invite them to listen to what we're saying. And again, pens up, we don't expect parents to be the nurses and provide nursing care for the child unless they want to participate. For instance, if the mother says, I'd really like to give my child a bath today, we're not going to say, no, that's a nurse's job. You can't do that. But we can offer to help and say, would you like me to bring you some warm water? Can I get you the supplies? Can I do part for you? Whatever it is, so the parent feels like they are being well cared for and the parents are not being excluded. Next, the pain medication. The child weighs 66 pounds, which pens up we know is converted to kilograms, which you divide by 2 to get the around the same number in your head, but then you divide by 2.2 to get the number, so it's 30 kilograms. The dose ordered for acetaminophen is 15 milligrams per kilogram per dose. The concentration of that is 160 milligrams in 5 mLs. So again, we know that the parents are at the bedside, calming the child, providing music. We give the child a stuffed toy. The pain medication, if you do the calculation, you might want to stop this video and try and do the calculation by yourself and see if you get the same answer. So what did you get? 14 milliliters is what you will be giving. So we're following the nursing process. We've assessed the child. We've diagnosed them. We know that they are post-operative in pain. We planned we're going to do these activities to decrease the pain of the child and provide comfort. We implemented that. We gave the medication. We provided music, comforting, stuffed animal. And now we're going to evaluate. Did it work? So now we're going to reevaluate the child, and we find that the child has a flax score of 0. The child is sleeping, they're comfortable, they are not grimacing, they're not arching, they're not moaning, they don't need to be consoled. So our management plan was a success. The parent is now satisfied, the parent is able to rest, and again, included in our family-centered care is our parents' well-being as well. The airway is clear. The child has only needed occasional suctioning of secretions. There's no bleeding from the ears or the mouth. The heart rate has decreased, the respiratory rate has decreased, and the blood pressure has decreased. So we know that we have done a good job at taking care of this child's pain management post-operatively. Thanks.